Everyone, and I feel like this is Zoom life, isn't it? And we all extend this grace to everyone, especially as we have people joining from Kenya. And so good evening to you. And I'm just so glad that we can host this presentation as part of our President's Student Leadership Institute, PSLI. This is the first year we've had a global leadership track. And it's a track for any student at University of Maryland, Baltimore in any of our 7 schools to join to learn about various topics within global health, global law, global social work that will help them develop an understanding of the different issues that are important within global leadership. And so we're so honored to have this group here today who have really successfully worked on this project, engaging youth in mental health approaches in Kenya and the US through the COVID pandemic. And I think it's a real testament to this team that they've adapted and pivoted to do this important work. So let me introduce people quickly. We have Tuli Katarere Virima. Hi, Tuli, who's a PhD student at University of Maryland School of Social Work. Her work is dedicated to the research and practice of culturally responsive healthcare, especially in resource-limited settings. Tuli has experience practicing community-based mental health care in South Africa, the American South, and in Northern Virginia, supporting clients from diverse backgrounds as they navigate the criminal justice, education, and healthcare systems. Also, hopefully joining is Robert Kimathi, who's a social scientist with over 10 years of experience in adolescent sexual reproductive health, HIV, gender-based violence, and mental health programming for adolescents and young people at research, policy, and practice level. And he is also currently serving as the technical senior advisor for the Mental Health, Digital Health, and Adolescents and Young People program at LVCT Health in Kenya. And Dr. Memia, who's an associate professor at the University of Maryland School of Baltimore, and also the lead on an NIH-funded program that facilitates the growth of scientists conducting technical implementation research. He has numerous publications and has led nationwide research, including adolescent and youth HIV sexual reproductive health assessments through UNICEF. He has extensive on-the-ground experience in Kenya through his work in adolescent health, gender-based violence, and HIV programming. Welcome, Peter, in Kenya. And finally, our last speaker will be Dr. Fernando Wagner, who's a professor at University of Maryland, Baltimore School of Social Work. He has been largely funded by NIH and is interested in the development of methods, knowledge, and community-based participatory interventions promoting wellness and public mental health. He has led participatory research in the US and globally for over 35 years and has directly mentored undergraduate, graduate, and postgraduate students. So I'm very excited to launch into this presentation. I think it's a great both international and interprofessional effort, and we're honored to have these speakers here. Thank you so much, and then I'll turn it over to you, Peter, to start.
Okay, thank you very much for the intro, and thank you all. Again, we want to acknowledge the Center for Global Engagement for funding this activity and always being responsive and supportive. And also everyone else who's logged in, and we also want to acknowledge the members of the Global Leadership Institute. So our discussion will be around engaging approaches for engaging youth in mental health. We want to keep the presentation short so that you allow time for questions and further discussion. Yeah, as you see, we are a team of 4 presenters. However, we are representing a huge community who we've worked closely with. Some of them are trying to log in or have logged in from Kenya, and so you probably get to hear their voices as we continue. So just to give an outline, we will talk about a little bit about the prevalence, the statistics around mental health in the US and in Kenya, and some of the issues in both countries. And then we will talk about the approach that is a premise for some of the work that we're doing, which is a community-based participatory research. And then we'll talk about our project, which is the Reach Mental Health Project. And then we'll finish by talking about what are some of the youth engagement opportunities, what have we done, and what else is out there. So I will hand over to Tuli to talk a little bit about the statistics. Over to you,
Sure.
Julie.
Thank you. So we just wanted to give a little bird's eye view of the mental health situation for adolescents in the US right now. These statistics are from 2009 based on a CDC report. So it's good to keep in mind that this was before the pandemic, which maybe makes them even more alarming because, as we know, the pandemic has exacerbated a lot of mental health issues for everybody, but for adolescents and young people especially. 1 in 6 youth reported having made a plan for suicide in 2019. 37% of high school students said that they had persistent feelings of sadness or hopelessness over the previous 12 months. This was true for significantly more females than males. The opioid crisis, which we've been talking about for years, has also been shown to be a problem with this particular demographic with young people as well. 14% of high school students reported having misused prescription drugs in 2019 as well. And when we think about the pandemic and all the lockdowns and isolation and disruption of our lives and this particular age group and how it's so important developmentally to, make those connections, to build relationships, and how disruptive the pandemic has been for all of us, but for this age group especially, you can imagine that these numbers are probably even more disheartening now than maybe they were in 2019. Next slide, please. So when we talk about Kenya, we just wanted to provide a little context so people know where we're talking about and what the situation is there. As you can see, it's highlighted in orange on the map. It's in Eastern Africa. The population most recently is estimated at 49 million. It is overwhelmingly a very young country. So you can see here, almost 28% are between 15 and 29 years old, and almost 40% are under 15 years old. So focusing on this age group, on adolescents and young people, makes a lot of sense in this setting specifically because it's a country that skews so significantly towards the youth. It was recently classified as a middle-income country. So there are resources for prioritizing healthcare generally, mental health care as well. And we wanted to make sure to highlight that there's a lot of geographical, ethnic, and linguistic diversity within Kenya. We'll talk later about our project and how it's centered in 3 counties, which are in different parts of the country, and how it's important when we talk about the continent generally, but even each country within it, not to take a homogenous view and to appreciate that the mental health challenges that people might be facing in different parts of the country may look different. There's practically universal mobile phone usage. Some people actually, the numbers were more than 100% because some people might actually have more than one SIM card. So using mobile phones is an efficient way of connecting with people because almost everybody has one. The Kenyan Mental Health Action Plan was something that came from the National Ministry of Health that laid forth a strategy for the country to increase access to mental health care for people across the country, to make sure that people with mental health disorders are treated with dignity, are protected in the laws, and also sought to integrate mental health care with other healthcare services in the country to increase efficiency and, again, access. Dr. Mamaya pointed out to me that it's interesting to note that Kenya has a national plan for mental health care, a mental health care strategy, but the United States does not have an equivalent strategy for improving mental health care in our country. Thinking about just trying to look at what the mental health situation looks like in Kenya, the World Health Organization found that 1 in 4 Kenyans is likely to suffer from a mental disorder at some point in their lives. And related to that, mental, neurological, or substance use disorders account for approximately 16% of disability-adjusted life years in Kenya. In 2014, there were only approximately 100 psychiatrists in the country. So there's a dearth of professionals, and usually they're centered in urban areas, which means everyone might not have access to mental health professionals. Looking at young people specifically, the prevalence of psychiatric morbidity seemed to affect children, this is primary school students, seem to affect primary school students in urban areas more than rural areas, which we just thought was interesting to know. Next slide.
Yeah. So the next few slides were supposed to be done by Dr. Wagner. He teaches this, so I'll try and do justice to them. And I think one of the things, and for most of us who also attended the Global Impact Conference sometime last year, there was an issue about, traditional research, where researchers come in to a setting, collect the data and leave and publish. So it's important for you to look at how best can we contextualize, how best can we start having more community-based participatory research with the people, with the constituents that we work with. So he had this, sometimes as researchers or as people who are living, for example, in the diaspora and coming to work in, for example, Kenya, we have to change the way we deal with some of the problems, mostly having a partnership approach where you have different community members, listening to them, having them as researchers, and having them equally involved, not just working with them and probably collecting data or having meetings with them, but making sure that they're equally involved throughout the entire process. Mostly the aim is to integrate bidirectional learning, we will hear some of the, we'll get some of the feedback, especially from Tuli and even from Dr. Wagner in terms of, how much they've learned from this experience. So the principles of community engaged research is mostly, reciprocal relationships where all of us are learning bidirectionally, co-learning, partnership, trust, transparency, and honesty. And we wanted to bring that out because that was the premise of our research approach when we applied for the funding. So I'll try and switch gears a little bit and take some time and talk about some of the work that we've done. What is REACH and what is REACH mental health? So REACH mental health is an acronym. In long, it's reaching and engaging adolescents and young adults for care continuum in health. And then we specifically say mental health. And it's because we had an offshoot, which was just REACH, and now we added the mental health piece. So now we call it REACH MH. It's, as mentioned, it's funded through the Presidential Impact Fund. And it's a collaboration between the University of Maryland School of Medicine and the University of Maryland School of Social Work. And then in Kenya, we have LBCT Health, who is actually one of the largest organizations dealing with adolescent populations in Eastern Central Africa. And then we also have the Ministry of Health, specifically the Division of Mental Health. This study was funded in July 2021, and our focus was in 3 cities. One, Nairobi, which is the capital city, and then Mombasa, which is by the coast, and then the other is Kisumu, which is in the western side of the country. So a little bit about the goals of our project, or some could say the aims. One was to review secondary data from the one-to-one digital platform. The one-to-one digital platform is supported by LBCT Health and the Ministry of Health, amongst different other partners, including the UN and I think Bill and Melinda Gates. So it is a platform for adolescents, and within the platform, they have a hotline. So this helpline, again, is one of the largest helplines for adolescents in Eastern Central Africa. They get probably about 6,000 daily calls from adolescents with different issues. So one of the things we wanted to do is look at the data and see what adolescents calling about. Mostly, would review the nature of the calls, duration, the service that they were looking for. So that was going to be our first goal. The second goal was to identify what are some of these factors that affect mental health amongst adolescents and young people. And this we would do using a digital app called the REACH app. So the REACH app is already developed. It's actually on Google Play Store and on the iOS Store. However, we wanted to refine it with now the mental health questions and also contextualize some of the questions that are in there. Then the third thing we'll do is to conduct targeted interviews. So these are like focus group discussions at different levels, but mostly to find out what are some of the barriers and facilitators of mental health services amongst adolescents and young people. So gathering all this information will probably help us in developing culturally and age-appropriate interventions for adolescents and young people. So these are the main goals. I would like now to talk about, what are some of the milestones we've done through engaging the youth. So as mentioned, we started our project around July of 2021. We started with a huge meeting, which was a collaborative meeting where we called different people who were engaged in mental health. And within the same workshop or the same meeting, we had about 40 adolescents. Think about 40 adolescents, different academicians, senior government officials, everyone engaged in mental health. We had a really fruitful conversation, lots of good discussion. And one of the things that actually emanated from this, we were like, this conversation is really good. Why don't we write up about it? So we wrote about it, and we've submitted the manuscript for publication. So these are joint manuscripts that has, authors, adolescent authors, and almost everyone that was in the meeting contributed towards this. And we also formed a community advisory board that keeps us in check in terms of what we are planning to do for this project. So it was around July 2021. Around October of 2021, we, as one of the things we had during the first workshop, during the stakeholder meeting, we talked about engaging adolescents, and we promised to do a series of workshops. This series of workshops would help empower adolescents in a way that they would be able to lead this research. So be on the driving seat to work with us from all the way from developing the tools to data collection to analysis to actually disseminating. So around October of 2021, we conducted the first workshop. It was like a 3-day workshop where we had about 45 adolescents attending. And one of the things that we keep on saying is that the retention was really good. So we didn't even have anyone dropping out. It was really interactive, highly participative. Again, a 3-day workshop, teaching adolescents about how do you ask the right question? What are some of the research principles, talking about even ethics, how do you ask some of these questions? But we also utilized some really cool technology. We used Jamboards. And for those of you that don't know what a Jamboard is, it's a Google product that can help do the mind mapping. So we'd put people in groups and they would have this Jamboard. So if you look on the slide next to the manuscript, so that's a kind of a Jamboard. I know it's not that clear, but we will share the presentation. You can be able to see. So that's a Jamboard where they were able to pick some of the concerns that they had, in terms of how to implement their research. So it was really good, very good feedback that we got from there. So between that time and now, we have been trying to update the questions from the Reach app. So we've had a series of meetings. Most recent meeting was on Tuesday. I think up to now, we've had about 4 to 5 meetings. This is meetings with adolescents where they're reviewing the app, the questions, and trying to find out are the questions appropriate. And again, remember, we are working in 3 counties. So some of the questions have to be fine-tuned depending on the county. So we've had quite a number of series of workshops for this. Then we continuously keep on looking for other grants to continue to support this project and impact stories. And then in the summer we plan to take 2 students for 4 to 6 weeks for them to participate in this exercise. So these are just some of the milestones. So the next slide, I don't know whether Robert was able to log in. Lauren, do you know whether he was able to log in?
I think Robert and Fernando are here.
Oh, okay. So the next slide, over to you, Robert.
Thank you. Thank you, Dr. Peter. Let me see whether I can be able to share my video. I don't know whether I'm being seen. So I will continue. I'll continue this on the meaningful engagement of adolescent and the young people. Thanks for the part. So one of our major things that we have been doing is putting the adolescent at the center of our design, of our implementation, and even at the level of policy and advocacy. So we do this for using a process that we really want to inform and through different approaches, we inform adolescent and young people across different parts of the country. Then thereafter we consult. This is basically to gain information and feedback from them, very objective, kind of the feedback that we need to get from them. Then thereafter, Dr. Peters explained this, we involve them, we work with them directly as at the core of the design. Thereafter, we collaborate with adolescent and the young people. In this way, it's more of a mutually agreed kind of the solutions. So we're not bringing them as spectators, but as equal partners in whether design, implementation, evaluation. Then thereafter, we do empower them to make sure that they can be able to go out as a self advocate in 2 or 3 levels. One is either a self-advocate, collective advocate, and then there's an entire element of giving feedback to the programs. So our basically approach looks at the 3 broad areas. The first one is as much as we want also to engage them, also giving them opportunities to learn through internships, through like the project that the REACH project is giving them, even local internship for them to learn and utilize the skills. There's also looking at opportunity to give them the employment for those who qualify. Of the great interest is the second, the Youth Advisory Champions for Health. This is the highest organ that advises us in terms of how the project need to look like. So we're looking at the element of self-advocacy. We are training them to self-advocate for the issues that they see at the community, at the regional level and the national level. And again, the collective responsibility of their constituents, of their young people within the community. Then the third level we are looking at, they operate within organized groups, organized organizations. So again, our role is to make sure that we do build the organization systems, standing for those organizations they come from, so that they become a movement, a voice, even at the community level. So all this, we do them through, again, through a human-centered approach that has been discussed, through the inspiration, ideation, and the implementation phase, like what we have been doing in the REACH mental health. So in nutshell, what I'm saying, adolescent and young people, they drive the agenda for our project, how we do it, at the community, at the local, at the project level, even at the national level. And that's what the REACH is anchored in. So again, and just to summarize of what we have done with the REACH in Kenyan context. So one, we have defined adolescent and young people as the primary stakeholders. They deliver, they tell us how they want things to be done, again, at individual and self-collective level. Then when we were designing this from the scratch, they were there to provide inputs in the goals. They are there to co-create with us in terms of the content, the language, the style, the feel, and how they want it to be organized, and probably the technological preferences. So sometimes we require this kind. Like for instance, the REACH Hub this week on Tuesday, what has been discussed, then gave us the feel, how they navigated through the hub and how they want it to look like, even in terms of the content. Again, we're dealing, Kenya is a multicultural kind of context. So for us, we're covering the larger part of the country. So we want to feel the current culture, the own culture, how do they feel, the insight, how they want us to deliver the interventions. Again, one of the things that have been happening, they've been left behind in terms of data collection processes, data analysis, and probably dissemination of the findings in the context that they don't have the capacity. But through the training that we conducted back on the community participatory research, we empower them. Now they can be able to collect the data in their own ways. Our lesson just to help them to interpret it and present it and disseminate it to different levels and influence kind of the advocacy processes. In Kenya, we are both national and county. So at the county level, what need to be done, county government, they are there, they advise the county government, and then collectively they put together to the national level for the policies and advisors as the implementing partners and other donors. So in summary, that's what we've been doing, and that's what the REACH project has been doing. So the next slide will be able to see just the photos of them smiling, of them doing co-creating virtually. Those are the photos of some of the youth advisory panels that how they're smiling and how they've been doing for the different meetings. So for us, meaningful engagement is not a what, is the actual doing of our design, is the actual doing of implementation, evaluation, determination of the results, and actual policy reform and advocacy by engaging the young people themselves. I'll hand over back to you, Dr. Peter.
Yes, maybe because Dr. Fernando joined and Manisha, maybe if there's something they want to contribute. Dr. Fernando, welcome.
Can you hear me?
Yes, we can.
Wow. Well, first of all, thank you, Peter, and everyone. A big apology. I don't know what happened, but the computer today is not working here. The Zoom is not working, so I'm joining by phone, as you saw. But I was able to hear at least half of the conversation. And what I wanted to share is that I mean, this is an incredibly interesting project. And what I have found is that what makes it even more interesting is the spirit of collaboration that has been shown by our colleagues in Nairobi, in Kenya, and in the different cities in Kenya, actually. I want to say how Dr. Mimia has been supportive of this process and engaged in giving us some on this information. But the one thing that to me stands out all the way is the participation of the different stakeholders and the engagement in the process. And we know that it always, as you said, Peter, it's very difficult it's time consuming to work with communities, with them to do research instead of do the research on them, but it pays really off because when people who are in a process of research identify that the researchers, especially from academia and other institutions, are trustable, that they are really committed to the well-being of the study and the people who are supposed to benefit the studies, then there's barriers that are lifted and new ways of new insights in which we do and what we do, just as you described with the youth participating in helping us define the ways of the research questions, the ways we should measure things, the way we should adjust the questionnaire and the app and everything. So I think I said a lot already, repeated a lot of the good things you already said. So I'm gonna mute again and let you finish.
Oh, that was helpful, and I guess that was our last our last slide. And we have a team monitoring the chat, so in case there are any questions but I'll hand it over to Virginia.
Great, thank you. And did Dr. Singh manage to, Dr. Singh, are you logged in?
No, I didn't see her.
Yeah, I don't see her either. Anyway, this is so fantastic. I know there's so many questions. Peter, maybe if you stop sharing your screen, and people who are comfortable opening their videos for this chat, please feel free to do so and ask any questions you have. Is there someone who wants to start first? I want to thank all of you for this great presentation, and with people coming in and out, I know that's not easy, but thank you very much. This is such an incredible program and so inspirational. And I'm so glad that you have 2 students involved who at least Tuli is able to be here. So who has a question for the group? So many should you, I'll start, but if you don't, if you want to put some questions in the chat, we can do it that way. But I did want to know, and maybe I'll start with you, Tuli, because you mentioned when you did the overview. What are you finding the mental health challenges for adolescents in Kenya are similar to challenges for adolescents in the United States? Like, what are the similarities and what are the differences? And I think that I just asked that question because this program seems so good. I wonder if it could be adaptable to the US.
So I'm actually gonna ask, so I've been on the research team for just a couple months and I haven't seen any data yet. So I was actually gonna ask Dr. Mamaya to jump in on this one. But part of why we wanted to look at the call center data was because we wanted to see how youth were describing their mental health needs and how, you know, because the language that they might use around the services that they're seeking, maybe we wouldn't think of it as a mental health need. Or maybe they wouldn't think to call it that when they called in, but it turns out that that's how it needed to be coded when they did call the call center. Beyond that, I'm not really sure what similarities there might be. I mean, I think young people, just because of this, like I said, this stage of development, like we are interested in common mental health disorders like depression and anxiety that we see all over the world, really. I was interested in this project because of some research that I'd done just on a very cursory level in Zimbabwe. So I don't know the details of the situation and the specific diagnoses that are maybe most common in Kenya. Dr. Mamaya, do you have anything to add?
Yes, I'll probably chime in. So one of the things, and I think I remember we had a slide on that, but we took it out, is some of the risk and protective factors amongst adolescents who are experiencing mental health distress are similar across, especially amongst urban adolescents. I usually give an example of, my son is 15 years, and when he's in the country, can actually come in and just like it really plugs in, because the same experiences that the youth in Kenya are the same experiences that they have in the US. Probably there could be a little bit of differences, but not major differences. But the issues are I would say are the same across the board. And we also have a number of some of the youth that we've been working with on the call. So I'll also ask them to feel free to chime in. Or Robert as well.
Yeah, I think you can just hand one or two things. When you look at the literature review that we did, because the question is the mental health issues in USA and in Kenya. And thanks, Tori, for bringing that issue. The issues that we are getting from the call center, issues of suicide, issues of drug and substance abuse, issues of anxiety, the issues to do with truancy, issues to do with, let me say, the physical violence that probably induced by other things. When you look at them, they are similar. They are similar, and especially in urban setup, the 3 city counties that the REACH project is targeting. When you look at them, they're similar. The mental health, the same age group, they're similar. Probably a little bit of how they interpret them based on culture, based on knowledge, what are the mental health issues, that might a little bit different. Now the interpreter and understand whether this is a mental health issue, but the real issue that they're experiencing, we are seeing them a little bit similar, even from our side. And even the 3 cities, they're almost similar in the local context in Kenya. And what they're asking for from different digital platforms, be it a call center, be it SMS, be it what they're looking for from website, they look similar, the same hinge. But really, I think is a discussion that now brings to us what's the best intervention for us to do, what can be replicated, and probably what can we be able to expedite as a learning lessons, like what Eugene is saying, to scale it in a different setup. So I'll let that to give someone else an opportunity. Back to you, Dr. Peter.
Yeah, this is Fernando. If I may also, I completely agree with what you're suggesting, Robert. That I mean, there are many things that are similar in terms of the suffering. The origin and the causes of this suffering may be probably different, and especially across different age groups and different race and ethnicity groups. But what makes this, and that links to the question that Virginia was asking in terms of how what we are learning in this international project in Help the United States. And I guess the first one is how through the participatory process, engaging youth in the process of defining what the problems are and how they need to be addressed, we are getting really a strong commitment from their part. And that helps us, for one part, measure things that they think are important, but at the same time, it helps us when the results are ready. I'm pretty sure the youth will be so engaged in all the different alternatives that we identified and different programs that can be advocated for and participated. So again, I think that what makes this particularly interesting is how the strategy of working in collaboratively in community engaged research allows the process to be more informative and more useful in terms of having practical results that can be shared and trusted by the community and different stakeholders. Thank you.
One question came to me directly that seems to dovetail with that is, did the advocacy role that adolescents took on in the project serve as therapy for them as well? Peter, I'll throw you. You're thinking of the answer to that. Do you? I do understand what that question's asking.
Yeah. I mean, I think I'll throw it to Robert. He's closer.
Yeah, I tried to answer it, and they are listening, and probably we can be able to answer. Yes, one, I'll say yes, partly, but not 100% substantiating my answer, but from the feedback that we've gotten from them so far. One of the best advocacy platform that we had is when we sat with the government agencies together and having a consultative workshop in the project. And the young people could be able to express to them what they understand as a mental health through the community participatory skills that they've learned, probably to define their problem, express themselves to different, both the national and the county government that were there, to express how they feel, how they want the mental health interventions to look like. So for us, when we sat with them there after on the scene, at least they heard us, they understood us. This is how we want it to be done. It's they look at it from our own perspective, that the interventions, the things that they're doing is the real things. There's a lot of things that the things that affect us, the things that how we understand them. So when you look from that perspective, yes, there's an element of acceptance of the mental health as a real issue in the country from the adolescent and young people themselves, and having a national discussion, listening to them, and trying to bring an intervention that is designed by them, and trying to create our entire awareness and other research and the data among them. I think it brings an element of the first line of accepting the problem. There's a problem, and from our own perspective, I think I'll put a comma there, because that is one of the questions that we'll be asking as we move forward as trying to answer. And back to you, Dr. Peter, if you have.
And just to add, mostly even just redefining the questions. As I'd mentioned, we had used the reach about a year ago, about 2 years ago in Kenya. However, now, in retrospect, as we look at some of the questions, a lot has changed. I remember the conversation we just had recently on Tuesday, where we had about, I think, 40 young people, looking at the tool, the Reach MH tool. There was a question that has been used a lot, especially to assess mental health. Different scales have used the same question, and the question is usually, do you turn violent? No, when you get angry, when you get angry, do you turn violent? It's a question it's in different tools, and it's, I would say it's one of those standard questions that you'll find under different instruments that are used in the Western world. But when we were looking at the question, there was a lot of discussion around that. You can be angry but not violent. You can be violent but you're not angry. So, and also the contextualization of that, and then also the link to mental health as well. So I think, one, the acceptance is there. Two, the people that we work with are ready to drive this conversation forward. They see the direction, and they see that there is a huge gap in terms of just mental health needs. The manuscript that we sent out, and maybe we'll share it once it's out, was mostly around that. We had, again, people, government officials, and different people from different sectors. However, the adolescents were very vocal in terms of our needs are not being had. As much as we have a mental health policy, but these are some of our needs, and these are some of the things that you should be looking at. I remember, and maybe Fernando, feel free to chime in. I remember we had one of the high officials in the government talking about some of the interventions that they're doing, and you could hear the adolescents saying, yeah, we understand about these interventions, but we are not feeling them, and the interventions didn't come from us. So make sure that even when you're doing such policies, we are part of the process. So I can't, I truly appreciate the learning just of the entire process, and we hope just from this engagement we'll have some really good mental health advocates going forward.
Peter, hi. May I also add one thought? And Virginia, let me ask if I can.
Please go ahead, Dr. Wagner.
Okay, thank you. Yeah, no, thank you very much. The one thing I want to say is, if I understood the question correctly, that if the participating in advocate is helping the youth improve on their mental health as well. If that's the question, I would say there are some benefits to participating in this process, but the only problem is that for some of the youth, they really need professional help. And so, and that's what I wanted to make sure that we never forget, that many things about mental health can be addressed through community and participatory process, with preventive interventions. But there are some cases that need special attention, that need a professional to help build a process of services, and those are always needed. Okay.
Thank you.
That's what I wanted to just highlight.
Thank you so much for sharing that. And that was a fantastic answer. And I see that Thomas Amache has his hand up. Thomas.
Thank you. Thank you, Dean. I just wanted to weigh on that question. One of the advocates from one of the cities, the coastal city of Kenya, and I want to appreciate the process because if I can say this is one of the best participatory approach that has been ever used, where we feel that we are involved in every situation. And I can even confirm that when we were doing even the reviewing the tool with colleagues, we were able to feel our inputs in there, and we feel the outcome is what we had suggested. And about the question whether the participatory has enabled us to able to address our own mental health issues, I can say yes. Individually, it has helped us, and to other levels that we are unable to solve, we are able to seek for help or refer our peers for help. And for instance, for Mombasa, which is one of the cities in Kenya, young people who are involved in this rich mental health program have been adopted in the technical working committee, which is the committee which involves the top officials in the government, in the health department, to discuss issues about mental health. So we are involved as under the technical working groups as key stakeholders in trying to ensure that the issues of young people are addressed from the policy level. So this is one of the best achievements that this process has brought us. We are able to address our issues. We are able to identify our problems, and we are able to share them with our peers. That is the best thing through the engagement we've had with the team. Yeah, thank you.
Thank you so much, Thomas, for sharing that important perspective. I'm glad you could join today. In the chat, I see that Professor Kathy Marconi asked, and Peter, you can decide who on your team answers this. Is U.S. mental health research this participatory in the U.S.?
Fernando, you want to take that?
I'm very sorry. I'm just.
You are unmuted.
Can you hear us now?
Just I have. Can you repeat the question? Sorry, because I got kind of distracted between the computer.
Yeah, no,
and the
thank
phone.
you. It's great to see you. Is U.S. mental health research, is U.S. mental health research this participatory as was described as it is in Kenya?
I don't think so. Unfortunately, we are a small group of people a small but growing and mighty group of people who are interested in participatory research. Unfortunately, there are, as Dr. Nimias showed, much of the traditional research is done with this helicopter model that corresponds to certain assumptions, and that we call actually, in terms of a Western tradition of research, that has also been related to colonialism. So, and just to explain a little bit of my own learnings in this project is that I am fully now understanding that we cannot do completely understand and address anti-racial issues in the United States until we also address anti-colonialistic. And this has a research, there's an epistemological challenge there, because it means that we have to do things in a different way. Engaging participants in research is not just a desire to have community members participate and that's it. It has scientific implications on what we study and how we study. So unfortunately, we don't have the same level of support and participatory process in the United States, as far as I know. But I want to say, but there are very different groups that are participating from different perspectives. So there are groups that are working, but the main approach has not been participatory, unfortunately.
I would definitely agree with that. And if I could just add, oh, I'm sorry. I see your hand, I'm sorry.
Go ahead, Tuli, and
Okay.
then Dr. Malinsky's, yeah, go ahead, Tuli, and then we can move forward. Thanks.
I was just gonna say that I think also because of the stigma of mental health issues specifically, sometimes you see participatory research in other types of even health research, but because of the stigma around mental health care, there's this idea that people who have mental illness or mental health problems can't participate in the same way. that I feel like is important to combat.
Thank you so much for sharing that additional perspective, and so relevant to the area of your studies for your PhD. So thank you for that. And Dr. Myslinski, do you have a question? You're muted.
Better? Okay, that's better.
Yep, now we can hear you. Great.
I apologize for the delay. I have three things. One is I see where Fernando is from the University of Maryland, and I have to say that the University of Maryland is a center of wonderful mental health research. And I think they should be given credit for that. Number two, historically, as I think a lot of people know, mental health has not been on par with physical health, whether it is funding at NIH, whether it's foundations and so forth. It's only recently that mental health has been given the recognition and the interest, I think, that it should have. Number three, it seems like COVID, not only at the University of Maryland, but throughout the country and the world, has increased the attention of the health profession onto mental illness, especially in our youth and the young people that we have. And number four, I am the founder of something called the International Brain Bee, which has to do with youth and neuroscience and psychological science. And I must say that Kenya, as a country, for years has been very much involved in the International Brain Bee, and I really, really appreciate that. That's all I wanted to say. Thank you.
Thank you so much. And so good to make these links. That's one value of having these webinars. So thank you, Norbert, for that. I have a question came to me, which dovetails with your comment, Norbert. How did the pandemic impact your research methods, and how did the pandemic impact the youth you were working with? And also, I should note, we have 1 minute, so let's just say Peter or Tuli or Robert, do you want to answer that quickly, or Fernando, and then we'll just have to say goodbye.
Fernando, you want to give it a try?
Well, it moved our timelines. We had thought that we would meet in person. We couldn't. There's a lot of people who are worried about the virus, so they are not participating in many things. And there's a lot of people who are experiencing a lot of stress during these times. So that makes it difficult. And there's time limitations. So everything is difficult nowadays.
Yeah, I think that you've probably described it well. Everything is difficult, but I want to conclude this session and just send a huge thank you to all of this amazing team that has worked through those difficulties to create a wonderful project. Any of the group from Kenya joining, thank you so much for being part of this and joining us today. And we're very grateful for your presence. And I found this very, very interesting, a real model for international and interprofessional research, and so glad to have both the faculty and the students. So thank you so much.
Well, thank you.
And if you look at the chat, you
Thank
can
you.
see the praise for this. We're very appreciative and hope we can interact more in the future.
Thank you. Thank you. Thank you.
Don't forget the 5K Kenya Connect that's going on all over the place to get money for Kenya and their youth and health and so forth. The Kenya Connect 5K coming up next month.
Okay, well, I will
Thank you.
definitely, if Norbert